and welcome to the 2026 Best of Lung Cancer Science podcast from the Society of Thoracic Surgeons that explores the latest science and innovations that are helping to shape our field. I'm your host, Dr. Erin Gillaspie, and today we're diving into the biggest lung cancer stories from the 2026 ASCO annual meeting and what they mean for thoracic surgeons. Joining me today is Dr. Jonathan Villena-Vargas. He's an assistant professor of cardiothoracic surgery at the New York Presbyterian Weill Cornell Medical Center, who was on site for ASCO reviewing the latest data. John, thank you so much for being here. There was so much exciting science this year. So let's just kick things off with your overall impressions of the meeting. What stood out to you the most on the lung cancer track?
Thank you, Erin. Thanks for the invitation. The biggest kind of talking point to me was, thinking about the Libretto trial and RET and basically molecular profiling and how much targeted therapy works, right? And in addition, there was something that, I'd want to discuss a little bit later on with regards to adjuvant therapy and actually a failed trial and kind of what that means to us in the immune checkpoint blockade. Also, there's been some interesting things, I think, about neoadjuvant therapy. This concept of potentially targeted therapy, again, making unresectable disease resectable disease, which I think we'll talk about as well. And basically a couple of smaller abstracts, but good studies showing that, bispecifics and ADCs are here. And, they're a little bit more of a complex backbone and treatment, but actually are making a big difference. And I think will reach us sooner rather than later.
I love it. That is just a perfect introduction to all the really exciting things we're going to talk about today. And since you brought up Libretto 432, let's jump off with that one. So, John, there was 2 lung cancer talks at the plenary session, which to me is just incredible, right? Lung cancer was sort of the redheaded stepchild for a very long time. And now we get 2 plenary talks. So to start things off, can we talk just a little bit about selpercatinib? I think a lot of people haven't heard this drug name yet, especially, we haven't really seen it in the earlier stage space yet. So a lot of thoracic surgeons may not be quite as familiar with selpercatinib, with RET mutations in general. What can you tell us about RET? What can you tell us about selpercatinib?
Yeah, so RET is kind of, if you go down the line, right, you have EGFR, which we had, such nice trials on, and now has become standard of care. You have ALK and all these trials and ALK mutations and how, Alina has changed kind of how we treat these. And then RET fusions, which are around 1% to 2%, the non-small cell lung cancer, mostly adenocarcinoma. I think it's important to know that, they had already had FDA approval in advanced disease and metastatic disease previously. And now, obviously, we'll go into this trial, how it relates to resectable disease. One of the important things about the RET fusion, I think, is that it's known to be immunologically cold, right? And right now, the only treatment we had in the adjuvant setting was really to give chemotherapy. In addition, it's much, much higher in the never smoking population. So it's really its own thing. And, 1% to 2% of non-small cell lung cancer is still thousands of patients a year. So even though the numbers seem small, overall, it's a large number of patients that are being affected directly by this trial.
I'm so glad you emphasized that point because people do get sometimes, I think, a little bit put off by the 1% to 2%. But when you add it both at a national scale and a global scale, it's a huge percentage of our lung cancer population overall.
Yeah, absolutely. And, and the data for this population, if you miss a RET mutation, you're doing a real disservice to your surgical patients.
Absolutely. So selpercatinib, you guys, it's highly selective. It's very potent, and very excitingly, it has great CNS penetration, which is something that I think is so important for all of our patients. Obviously, CNS disease, very, very toxic, and it's a RET inhibitor. And as you mentioned, John, it is already approved in the metastatic non-small cell lung cancer space based on some prior trials. And really because of its safety profile, if its efficacy in that metastatic space, it's really not a surprise that people moved it, fairly hurriedly into that earlier stage space. So take us through the Libretto 432 trial schema so that people understand how this trial was set up and how these patients were studied.
Yeah, absolutely. So this was a phase 3 double-blinded randomized controlled trial in 22 countries. It included 151 patients. Basically, it was everyone from stage 1B to 3A with a RET fusion and non-small cell lung cancer. It was basically after definitive surgery or RT, so with curative intent. The important thing also is that it's a BID drug, and they compared it to a placebo. And the primary endpoint was actually in stage 2 to 3A disease, of which 109 patients were looked at.
I'm really glad that you specifically highlighted the radiation piece, because I think a lot of people in the audience, when this trial was initially being presented, didn't catch on to that right away. And all of a sudden the numbers got smaller when they were looking at sort of the surgery cohort and sort of talking about some of the nuances of the trial. People were like, where did those patients disappear? And it's because it was local therapy. So it was after definitive, successful local therapy, these patients were randomized to either sort of the RET arm or the placebo arm. And as you mentioned, stage 1B all the way to 3A, we're specifically studying that 2 to 3A, which has sort of been universal across all of these trials. And we include that 1B cohort, but the primary group being evaluated and studied is that 2 to 3A. Okay, so let's talk results, because this was very, very exciting. And so they presented 2-year EFS data. How did the patients do?
Well, yeah, amazingly well, right? The 83% reduction in recurrence and death. The hazard ratio was 0.17, which is incredible, but not unheard of now in targeted disease in this space in these patients right now. And 92% event-free survival. 60 versus 61% EFS in the placebo arm. So it really makes a huge difference. I think it's also important to note, just like we said before, around 70% of these patients were never smokers and overwhelmingly adenocarcinoma.
Yeah, absolutely. So yeah, the hazard ratio is 0.17. I mean, those are the ones we dream about, right? That we hope for. And it's very comparable to what we saw with the ADORA trial, with the ALINA trial, those, very low double-digit hazard ratios. And so, one of the really buzzy things that I think happened right after this talk is clearly everybody said, hey, we have to start testing all of our early stage patients, our locally advanced patients, EGFR, ALK, and RET. Absolutely critical. We need to get selpercatinib approved so that we can start giving it to our patients as soon as possible. But I think the other really buzzy thing that everybody was talking about is we have all of these targeted agents now in the metastatic space. How do we more efficiently, effectively, and in less time trickle these down into the earlier stage spaces, because they're making such a monumental difference in the event-free survival? Do we need to start thinking more about pragmatic trials, bucket trials, so we can get these drugs to our patients faster?
Yeah, I mean, I think that it just makes sense, right, to do that. But, I think that these very, very well-run trials with these amazing results are practice changing immediately, right? It's published immediately in the New England Journal of Medicine. It adds to armamentarium. I think that the one thing that I did notice about this trial was that 67% grade 3 or plus event, right? And around 20% or 17 to 20% of these patients, stop taking the drug. Right, which is supposed to be for 3 years. So, that's just something to add on. I mean, these are not inert, right? It's not all positive, right? They can, they have their downsides as well.
Absolutely. And I'm really glad you brought up the toxicity, because that actually has been one of the biggest concerns with moving some of these drugs from the metastatic space to the earlier space, because we know people who have more advanced stages of disease, who often will be a lot more aggressive from a treatment standpoint, or a lot more willing to tolerate side effects with the benefit of time, which might feel a little bit less obvious and tangible in the earlier stage space where we know the cancer is completely out. The patient really wants to feel a lot better. They know the cancer is gone. And so really being thoughtful about some of these side effects. One of the biggest ones for this, obviously, is sort of the hepatotoxicities, the elevated LFTs, which, as you know, does require sort of that either drop down or cessation of treatment in a portion of the cohort.
Yeah, no, that's a great point.
Okay, so let's switch gears just a tiny little bit. So we know now that we need to be testing our patients. So call to surgeons, test everybody, EGFR, ALK, RET mutations. We now have treatments. It's very, very, very exciting. We will, in the notes for the show, include the New England Journal article that dropped the same day as the presentation. Super exciting. And we'll drop the ASCO slides as well, so you can see the beautiful curves. But I want to switch gears just a little bit to the other plenary presentation. Now, guys, this is in the advanced stage, but I think it's really important because It actually perfectly goes into one of the comments that you made earlier, John, which is about the bispecifics being really sort of a buzzy topic, and really these combination therapies becoming really an important piece of metastatic space and moving into the neoadjuvant space. And I think it's just a matter of time before we start hearing about some of these drugs here. There's already neoadjuvant trials that are ongoing overseas. And so we're going to talk a little bit about the Harmony 6 trial.
Yeah, I think absolutely. We have to highlight this trial because, as you're saying, everything is going to be moved to earlier and earlier stages. I think what an important thing to note about the Harmony 6 is that this is a a Chinese study, a Chinese drug. Everything was developed there, and I think it's the first time that a Chinese-led drug was presented at ASCO in 60 plus years. So that just shows you kind of the globalization and how big of a push these global trials have been coming up with.
I couldn't agree more. It was really exciting. And that actually was one of the announcements that was made, which was so cool. And there was 2 drugs that we don't talk about as frequently that were included in the 2 arms of this trial. So it's ivonescimab, which is the bispecific. And so that targets PD-1 and VEGF. And part of our conversation is going to be very specific to the VEGF. And then tislelizumab, which of course is a monoclonal antibody against PD-1. So we have sort of those 2 different drugs included in our 2 arms of this trial. So talk to me just a little bit about the trial schema, how they organize things, and then we'll delve into some of the results.
Yeah, for sure. So as you said, it's a PD-1 and VEGF inhibitor. VEGF is supposed to stop the blood vessels from forming, and sometimes it regularizes it so the drugs can penetrate better. It's supposed to kind of decrease the immunosuppression, so it may actually help the immune checkpoint blockade. This was a phase 3 randomized controlled trial in 50 hospitals in China. It recruited 532 patients with untreated, unresectable stage 3B, C, and stage 4 squamous cell cancer, only squamous cell cancer. I think you'll go into this a little bit, but 93% men. Yes. The median age is 60%, overwhelmingly stage 4 disease, right? So over 90% was stage 4. And basically, like you said, is comparing this PD-1 VEGF bispecific versus a PD-1 inhibitor alone. And the primary endpoint was PFS.
Absolutely. And I think one of the things that is so important to highlight is something that you mentioned with VEGF specifically. And so one of the concerns with sort of our historic experience, I guess, with VEGF, which is mostly bevacizumab, right, is that what's one of the complications of it? Bleeding. And so when you think about the inclusion criteria for this trial, one of the really critical things is these are stage 4 patients who didn't have sequelae of bleeding or high risk for bleeding. Included squames, which I always get very excited about because I feel like a lot of our trials are very dominated by adenocarcinomas right now, especially, of course, in the targeted space, which is where we really see all of those taargets evolving and dominating. We see those less in our squamous cell space. And so really exciting to see a trial that's specifically tackling really a cancer that maybe gets a little bit less attention. So talk to us a little bit about the outcomes of these 2 arms.
Yeah, so it was, the addition of the VEGF bispecific had a, median overall survival of 27 months or almost 28 months compared to 24 months of the PD-1 or tislelizumab alone, with a hazard ratio of 0.66. So 34% decreased risk of death compared to the standard of care, which is fantastic. I think it's also important to note that it didn't really matter what the PD-L1 level was, right? It was the same hazard ratio, whether it was less than 1% or the PD-L1 expressors. So, again, really good results, which is, it's a step forward, right? That's probably going to come to earlier stage disease.
Yeah. Absolutely. So we have definitely a benefit from a progression-free survival standpoint. It's always so humbling that we talk about survival in a matter of sometimes, or progression-free survival is like 4 months of benefit, but that's a huge deal in the metastatic space. And I love that you brought up specifically about the PD-L1, right? And so we think about PD-L1 status often, and we usually do see that enhancement of outcome as we go up the PD-L1 spectrum, with the less than 1% not performing quite as well as the 1% 41 to 49, not performing quite as well as the over 50 and then the over 80. And we see really good performance in the PD-L1 negative. And actually, a lot of the patients in this trial were PD-L1 less than 1%.
Yeah, I couldn't agree more. It shows you kind of the rationale. They were right on the button, right? You can see how in the past other kind of lesser checkpoints have been added to PD-L1 or PD-1 inhibitors, and they haven't really worked. But this one specifically, as well as another ADC that maybe we'll touch upon later, really, it's the rationale's there, the mechanism is there, and it paid off.
Yeah. Absolutely. Now let's dig into a little bit of the nitty gritty, because there was a lot of conversation around sort of the broad applicability of this trial. So we've touched on a couple of the things. So first and foremost, 100% of the population was from China, which does have some implications about sort of the broad applicability across the entire world. Will we see the same type of outcomes? Dominantly men, so there's about 5% women in each arm. I don't know if that speaks to the population in China, that really men are dominantly impacted by squames. Maybe women have higher adenocarcinomas. I'm not sure. And then age. So one of the really interesting things in this trial about age, and that we're seeing sort of in trials across the spectrum in metastatic, is unsurprisingly, we see much better performance of the drugs in a younger population. They tend to be able to tolerate side effects better. They stay on treatment longer. But in this scenario, it really looked like the population below 65 performed the best, and then over 65 didn't perform quite as well. And gosh, that to me is young, because, a huge percentage of the population we take care of is well into their 70s, 80s, sometimes even 90s. And so if these drugs don't perform quite as well, or perhaps have a side effect profile that isn't tolerated to 65, that might really limit the applicability of this drug.
Yeah, you bring up a great point. I think that the differences in age, and there's a lot of actually immunology and science about the immune system and how age is directly affecting it, with older patients not having as good a baseline immune system, and maybe these checkpoint inhibitors don't work as well. I completely agree with you.
Absolutely. So we must stay tuned for Harmony 6, see how this continues to evolve. But guys, it sort of seems like VEGF might be returning to the conversation in a little bit of a bigger way in the form of a bispecific. So keep that in mind, because this is already being evaluated in the neoadjuvant setting. So they did a very small phase 2 trial with ivonescimab in non-small cell lung cancer. The overall survival and progression-free survival data is maturing at this time. And then it's also entered the conversation for head and neck cancers, which, as we know, are dominantly squames, and breast. So stay tuned for more with regards to this drug. Okay, John, we have to dive into AI next. It seems like AI is actively trying to take over the world. We see it at every conference now. It's one of the dominantly submitted abstracts. There's entire sessions being dedicated to it. You were one of the incredible planners for ASCO. Talk to me about AI and ASCO.
Yeah, so it's interesting, right? So they give us kind of, as part of the planning committee. It was my first year in the planning committee for local regional lung cancer. They have a projected kind of abstracts, like the amount of abstracts that we are thinking that we're going to get every year, and the amount that we have to review, just kind of planning for the committee and how many abstracts you have to read and divvy it up. And we were well over the projected submissions by 100-fold. Not 100-fold, but 100 abstracts. But there was a huge uptick of these AI or machine learning abstracts. Right. And some of them are exciting, but parsing out which ones are exciting versus how we actually validate these is going to be a big change in how we evaluate a lot of these things, because obviously the methodology is incredibly complex, and trying to, parse that out in an abstract form can be really difficult.
Absolutely. Absolutely. Now, the very interesting thing too, a lot of conferences is we're seeing that the AI is being used in creative ways across the spectrum of all cancer, right? And so they're saying, hey, we can apply this technology to breast, to, sarcoma, to lung, to everything, which is really interesting too. And so we see some of these studies coming out and they just say cancer. It's not even a specific cancer, it's just cancer.
Yeah, no, absolutely. It's incredible. I mean, in addition to kind of the algorithms that have come up, you have these cohorts of data that are now amassing, right? Like you said, in all cancers, right? That can be mined for these.
Okay, so let's talk about one of the buzzier AI studies that was talked about at the meeting, and it is using a Da Vinci model. I love that we're starting to use artists to name all of these different pathology studies and AI tools. I mean, let's face it, pathology is beautiful. It does look like a work of art, so, very, very apt. So talk to me about this Da Vinci study and what we learned from it.
Yeah, so this was basically validating this Da Vinci platform in order to read pathology slides. So they looked at almost 9,000 patients and used this Da Vinci platform. And interestingly, it was able to diagnose in about 20 seconds with over 90% accuracy, better than the actual pathologist, a lung cancer. So that has implications for a very robust way of reading and kind of getting rid of that inter-observer, between pathologists, how they may miss things. But in addition, it's incredibly efficient. So this was a really robust kind of, out of all the AI submissions, this one stood out.
Yeah, absolutely. And I think this is not a call by any means that anybody is making to replace pathologists. It's just trying to think of creative ways that we can enhance, right? Sort of like we've done with AI and radiology, being able to get a very quick read on something to help make decisions about proceeding with resection. I mean, let's face it, not everybody's lucky enough to have a great cytopathologist at bedside during diagnostic attempts. And so having these tools to be able to say, yes, you have adequate specimen. Yes, you have diagnostic specimen. Yes, you have a cancer. Please proceed with, mediastinal staging or whatever your next move is going to be. I think this is going to help to make care more efficient and really transform, especially that early sort of diagnostic stage with of course, the pathologist reviewing and confirming.
Yeah, no, I think that makes a lot of sense. And, like you said, just like radiology, it's about being efficient. It's about removing error, and it's a tool, right? It's not a replacement. So I think, I would be grateful to be, if I was a pathologist, to have this, available.
Yeah, absolutely. Absolutely. And certainly as they continue to train the model, just like with any machine learning tool, you continue to train it with more samples and it just gets better and better and better the more it's able to see and repeat the exercise of reviewing the slides. And so, they trained it and used it for 9,000. And so, it'll be really interesting to see how well it performs once it has 1,000,000 training slides.
Absolutely.
All right, let's head back in to drugs. So in addition to obviously our very exciting libretto trial, we also had a neoadjuvant trial. This is called the Lauren trial. This is with lorlatinib, neoadjuvant therapy. So more drugs moving into the earlier stage space, this time before surgery. We've seen a lot of the drugs initially move after surgery because we know that we're not going to have to worry about the side effects. We're not going to have to worry about the impact on surgery, but we are seeing them come into the neoadjuvant. We have the NeoAdora trial, obviously, which is going to continue to report out. And now we have Lauren. So talk to me about the trial schema, and then we'll dive into some of the results.
Yeah, so Lauren, it was an interesting schema, I think.
I agree.
It was a very elegant one, I think, with regards to resectability. So it's very surgeon kind of minded, I think. So basically, it was a phase 2, Simon 2 stage. It accrued 43 patients, and it was stage 3 ALK positive non-small cell lung cancer that included unresectable disease or potentially unresectable disease to be reevaluated. They got 3 cycles of neoadjuvant lorlatinib, which is the ALK TKI, and then with the primary endpoint being pathologic complete response in both arms.
Absolutely. So continuing to see pathologic complete response be this huge surrogate marker for us for efficacy of therapy, one of the huge benefits of neoadjuvant, right? Because we get that in person, in patient trial. Is this drug going to be really effective for this person, which we all love? And it's phase two. And I agree. I loved the design of this trial because there are a lot of patients who are borderline resectable. There's a lot of complex decision making we have to make. There's a lot of times we're trying to get one additional test, right? Whether it is a VQ scan or an MVO2 study to help determine a patient's fitness for resection, or we need an additional study to see the relationship with a particular structure. And to me, the benefit of having somebody on an effective drug while I'm doing that, man, that's the dream, that I can get all these additional studies and then have the ability to either go down a surgery pathway or pivot and go down radiation if things aren't looking the way that I want them to look. And so I love trials when they are designed in this manner, very MDT bridge.
Yeah, no, absolutely. And and it gets, the surgeon right there in the middle of it, right? Resectability is such an important point and such an important concept that, it's a surgeon-based decision, right? And this kind of brings that forward, I think, but yeah, go ahead.
Absolutely. So, okay, we have to talk about how this drug did because I will tell you, I think this was sort of a showstopper because we really, for a long time, have sort of mentally placed these drugs in a category of, hey, this is going to shut down the pathways, it's going to turn off these cancer cells. So, well, maybe they're not going to kill that many cells, but we're going to shut down the pathways so they can't continue to propagate and grow. We saw in the NeoAdora trial that we had sort of this 6% pathologic complete response rate. I was sort of mentally preparing for the same here. Talk to me about how these drugs, how lorlatinib performed in this setting.
Yeah, I mean, it was an incredible, almost 47% pathologic complete response. I mean, it really, really made a difference, right? Both in the resectable and unresectable patients. And I think what's the most important finding that I saw, speaking as a surgeon, maybe biased, was that it converted 75% of the patients were converted from unresectable to resectable disease, which is
Yes.
incredible.
Yes, I agree. And even, when they first talked about just the objective response rate, right? So just radiographically, we have like 84% of people who have an objective response, no progressive disease, R0 resection rate. We are doing so much better with our R0 resections. I was really disappointed in some of the earlier trials when we were operating after neoadjuvant that we had, some as low as, the mid 80s. We're at 97% for this trial. Majority of patients being done minimally invasively now, which again, huge difference from some of those index trials. And PCR nearly 47%. I think the major pathologic response rate was almost 82%. So that's less than 10% residual viable tumor in 82% of patients. And then for me, the other really exciting thing was the pathological nodal downstaging, right? So 90.6% of patients had a pathological nodal downstaging. And so, to me, that starts getting into this really important discussion of what's the limit of what we should be thinking about with regards to resectability if we're able to eliminate all nodal disease, including N3, if we're able to shrink down tumors and we have a small amount of residual disease. I think more and more we're going to be talking about using really aggressive local therapies, whether that be surgery or radiation, in these patients to assess the true, response, looking at the pathologic response under the microscope. But two, I think it opens up stage 3 and stage 4 to us in a really huge way.
I couldn't agree more. And just, again, to highlight a little bit of the surgical outcomes, which you were saying earlier. I mean, as a surgeon, the fact that, 90% of these were done minimally invasive, right?
Yes.
They did convert, but like you said, an R0 resection rate of greater than 95%, which is
Yeah.
incredible,
Yeah.
right? So I think that, as we advance, right, as we do more neoadjuvant surgery and we're more used to it, and, we're more used to these complex surgical resections and kind of the nuances of who we have to treat open, who we have to treat minimally invasively. Just technically, I think we're getting a little bit more experience with it, and I think it's paying off.
Absolutely. The other really interesting thing in this trial is of the patients who recurred. So again, a small trial. This is really, it's a phase 2. We're exploring this new opportunity, but only 3 patients actually experienced a relapse. Most of them were regional lymph nodes, no distant metastases. So, gosh, and all of them presented with N3 disease, right? Speaking to sort of a higher level of sort of that stage 3, these are the patients who were considered unresectable up front. Only 3 of them had a local recurrence, not even a distant recurrence. So again, there's more opportunities for local control in these patients with really extraordinary 1-year EFS rates. So, event-free survival was 97.1% at 1 year, early, but still really, I think, a home run.
Well, 100%. They did say that of those 3 patients that recurred, they did not receive any adjuvant TKI or lorlatinib.
Correct.
So, you know,
Correct.
there's still room for growth, even for those few patients that actually relapse.
Absolutely. So we have alectinib for adjuvant space. We've been using that for a while. Highly, highly, highly successful. Stay tuned for what's going to happen in the neoadjuvant space. I know they are studying alectinib in that capacity. We've got lorlatinib studies ongoing. We need to continue to see how this trial evolves. But my expectation is we're going to continue to see a lot of really positive outcomes in these ALK trials that are going to continue to change the way that we're taking care of ALK positive patients.
Couldn't agree more.
One of the things that I love about that trial is I think it perfectly leads into our next discussion. And I really want to chat just a little bit about trials in general and this adaptive trial design that we're seeing really emerge as a big part of conversations. It was a really lovely part of John Spicer's discussion. One of the things that I love about ASCO is with every plenary talk, there's a discussant that comes up to follow. You guys do great debates that really highlight some of the important conversations that are taking place across all cancers, but for lung cancer, it was really exciting to hear everybody's thoughts on these adaptive trial designs and how we need to be thinking creatively about escalation and de-escalation. So talk to me a little bit about what we are hearing about with contribution of components, escalation, de-escalation. What does this mean? How is it changing trial development right now?
So one of the most important kind of conceptual shifts in oncology and has direct surgical implications has really been about escalating and de-escalating. Basically, for the last decade, the dominant paradigm was to add immunotherapy to chemotherapy or add adjuvant therapy to surgery. And that has been, incredibly productive, right? With all of these trials, as you guys all know, Checkmate 816, Keynote 671, Aegean, and such. But the counter narrative is really, how do we actually remove or how can we tailor these therapies to the patient's actual response, right?
Yeah.
Good trial to show that.
Yeah, absolutely. 95.3% of people alive at 5 years, if they have a past CR, I mean, just unbelievable. Unbelievable.
Yeah, unbelievable.
All right. So let's talk sort of big picture discussions. What are some of the other key highlights that you think are really important to bring to our listeners from the ASCO 2026 meeting?
So I think the key takeaways are that, first of all, you have to have reflex molecular profiling. I think that's mandatory. And I think it's critical that you see now with the libretto trial and RET, in addition to ALK and in EGFR. I mean, you're really doing a disservice if you don't find these mutations and treat the patient accordingly. That's critical for everybody now. I think that this concept of unresectable to resectable disease, which we see in the Lauren trial, was so critical for just kind of how we think of what we can do next, right? And just the same as you said, who are we thinking is resectable, unresectable? What are the uncharted territories in stage 3, stage 4 disease that we can potentially operate on? I think that's critical, and I think that In addition to that, in addition to escalating and de-escalating and thinking about what the next steps are, we're seeing now that bispecifics and ADCs do work, right?
Yeah.
They are making a big difference. So it's no longer just checkpoint. It's these checkpoint plus, these very much more nuanced and maybe potentially complex backbones to these checkpoints may make a huge difference. And I think also, one of the talks that we chose, and I think is very critical, was that screening VA study, which I know we didn't discuss, but it was basically almost 1 million VA patients.
Yep.
Showed that if you are able to kind of simplify who gets screened, you're able to detect much more cancer, and especially in these kind of underserved populations. So I think that should be highlighted as well, and hopefully, people get that message across that we really need to simplify who we screen and get that across.
It needs to be simpler. It needs to be accessible. It needs to be reproducible everywhere. And the VA is just doing such a tremendous job with it. They've really, really moved the needle forward significantly.
Couldn't agree more.
I love it. I love it. Well, gosh, this has been such a wonderful discussion. I think the last thing that I would love to pick your brain on, I think surgeons more than ever are really being asked to be thoracic oncologists, right? We need to know about the mutations now. We need to understand these drugs. We need to figure out how to safely manage our patients around surgery. And there's a lot of evolving pieces to this. So what are you doing in your program to make sure that the multidisciplinary teams are interfacing seamlessly? How are you passing these patients from oncology to OR back to oncology? Give us your tips and tricks for making that as seamless and successful as possible.
Yeah, no, I think you have to start with a team approach from the get-go, right? From the outset, right? Get everybody involved, even in very early stage disease, because these patients do want to talk to an oncologist, even in stage 1, even with these high risk patients. Even if you have a stage 1 patient that has a mutation, I feel like they want to know more. And it's very easy for me to to have them speak with an oncologist, to have that patient discuss with an oncologist and see what does this mutation mean? I think that it's almost like, again, back down to a grassroots way of doing things, in which, you really have to get on the phone, speak to everybody, have these joint meetings where you decide together what the best way forward is. The one thing that I do know is that oncologists want to know as much about the surgical patient as we want to know about the drugs and the further treatments, right? What are the side effects? What is this patient willing to tolerate? How difficult is the surgery for this one specific patient, right? What are the complication rates? I mean, I think everybody wants to know these things as a team. So the more the merrier.
I love that. I love that. And honestly, being able to be in that multidisciplinary setting, having the oncologist to share clinic space with is always a dream. And honestly, attending meetings like this, it just fosters incredible discussion. The oncologists want to hear from us. We want to hear from them. We want to understand these drugs. We want to make sure that we're providing the best possible surgical care. And so I love all of your thoughts and comments on that.
Well, thank you, Erin.
All right, you guys. So if you haven't been at all on social media since the meeting, you no doubt saw the extraordinary moment that daraxonrasib was presented at the plenary. And you guys, this is a pancreas drug, but I will tell you unquestionably, it was one of the coolest moments that I have ever had at a meeting. It was the oncology version of the Venice Film Festival. There was standing, there was cheering, there were tears, but most importantly, finally hope for patients. Daraxonrasib is a pan-RAS inhibitor, and it was studied in the second-line metastatic for pancreatic cancer, and it doubled the overall survival for patients. So a cancer that was once considered undruggable has a major advancement for the first time in about 40 years. What an incredible time to be in medicine and be in the cancer field.
I couldn't agree more.
For our listeners, you guys can find more information and related resources at sts.org and in the show notes. Until next time, I'm Dr. Erin Gillaspie, podcast host at the Society of Thoracic Surgeons. Please follow the 2026 Best of Lung Cancer Science Podcast Special Edition series, now available on all popular listening platforms, including Apple, Spotify, and of course, iHeart. And don't forget to follow me on Thinking Thoracic, an STS podcast that offers candid conversations about the latest advancements and challenges in thoracic surgery. The podcast is also available on your favorite listening platforms. Keep smiling, guys.